On, we have Dr. Kaplan.
Hey.
As he just mentioned, going to be discussing rheumatoid arthritis. Thank you so much, guys, for turning your cameras on.
Yes.
All right. I'm going to mute myself, and I'm just going to hand it over to Dr. Kaplan.
Yeah, it's a pleasure to be here. Thank you, guys. Can I have head nods if you can hear me? Good. Okay. So nice to meet everyone. I'm scrolling through the list here. I see several rheumatologic all-stars who I have met already. And for those of you who I haven't met, it's so nice to e-meet. I think the Zoom lectures really aren't as fun as in person, but it's better than nothing. But so cool. So what I'm going to do is over the next hour, we're going to review some basic stuff about inflammatory arthritis. And this is totally meant to make your clinic life more fun and more useful. This is not meant to just be something that we run past. And you'll see that the case I'm going to present is something you guys see every day. So without further ado, let's dive in. I'd like to wish everyone a happy Hanukkah, by the way. Okay. So a case for our residents of excellence. I'm also just going to be calling on people. So if I call on you, don't at all worry. I'm going to throw everyone softballs. It's going to be easy. Okay. So Ms. Rodriguez is a 72-year-old woman with hypothyroid, diabetes, hypertension, lipedema, and sinusitis. And she's been feeling unwell for about 3 to 4 months now with diffuse achiness, joint pains everywhere, and poor sleep. Tylenol isn't doing the trick. She comes to you with recent labs with an ANA of 1 to 80 speckled, negative RF and ESR of 45. She says her mother had arthritis and was unable to use her hands. Secondary to severe pain, she's concerned she has inflammatory arthritis. Can I have a head nod if anyone has ever seen a patient like this? Right? We see them pretty frequently, right? So our learning objectives today are to improve our clinical reasoning skills in the patient with diffuse pain. We're going to understand the seismic importance of inflammatory pain. We're going to improve our goal-directed physical exam and refine our understanding of a few key labs. And an ANA could be a full morning seminar from 8 a.m. to 12, but we'll go over some major points about what an ANA is. So how we're going to do this, we're going to do a history for 10 minutes, physical for 10 minutes, labs and imaging for 10 minutes. Then we're going to do wrap up with a little PowerPoint and questions, concerns, and existential musings in the last few minutes. Okay. So we just went over the history. So just to reiterate, this is an elderly woman with multiple comorbidities, including the vascular and the sinusitis. She feels unwell with diffuse pains, arthralgias, and an ANA of 1 to 80 speckled and an ESR of 45. So let me ask Dr. Pietro, what is the goal of this encounter with this human?
Hi. So we need to figure out, tease out her pain a little bit more. When is it occurring and in what joints, to try and narrow down how we can further work up her case, and also to provide her with some kind of pain relief by the end of our encounter, because that's her main complaint, is her pain.
Totally, Jude. And I just want to reiterate the last thing Dr. Pietro said. Our goal is to help minimize suffering in this human, which I think is sometimes lost on us as we go through residency and learn all about cardiac caths and all kinds of advanced pathologies and procedures. Here's a human being who's suffering. They come to you with a white coat and a stethoscope and they say, make my life suck a little bit less. Help me feel less pain. Right? And so our goal of the encounter is to do that. And sometimes in patients where it's not clear, if they don't have crazy high titers of some lab, or if they don't come in with classic hallmark features, it's very challenging. So our goal, like Dr. Pietro said, is to minimize suffering in this human. And how are we going to do that? First, we make a differential. And what is kind of at the top of folks' differentials? What are people thinking? I'm going to call on someone else. Just there's no wrong answers here. There's some common things being common. Next on my list is a Dr. Rafael Madero. I'm wondering if Dr. Madero could tell us just 1 or 2 things at the top of his list.
Yes, I love how you're picking on the cheese now. Dr. Madero.
No problem. I don't think he can hear us. Dr. Horowitz, anything top of your list?
Yeah, I mean, I'd possibly say rheumatoid arthritis.
I mean, it's a good guess, right? Where it talks about inflammatory arthritis. Very good. But even before we get into inflammatory stuff, what's just common things being common? Elderly woman not feeling well. What's some kind of primary care stuff you guys think about?
OA.
Yeah, OA. OA is a great thought. Who else wants to chime in? What else do we think about here?
I can even think of depression.
I would think polymyalgia rheumatica.
Okay, PMR is a good thought. PMR is not as common as some of the other. It's a good that you're thinking of it, just because it tends to happen in folks of this age, right? It's often comorbid with giant cell arteritis, which is the most common vasculitis in people her age. But really common things being common. OA is a good one. What else do we have?
If you can read the chat.
Oh yeah, maybe putting it in the chat might be a good idea.
So we said like degenerative arthritis can be the top of our differential. We said
Great.
inflammatory osteoarthritis, lupus can be in the differential, given that she had a lot of autoimmune disorders as well in the history, the hypothyroidism, diabetes. And we can put also like crystal-induced arthritis, like CPPD, gout.
Yeah, so very good. I'm now seeing in the chat that people are putting stuff. I'm sorry, I didn't see that. So good. So I love that thought about the different kinds of inflammatory arthritis. We're going to get to that in question 3. The general differential at this point should probably include non-inflammatory arthritis first. Things like fibromyalgia, classically OA is not thought to be inflammatory, although that's a changing paradigm. But OA, fibromyalgia, things like depression, good. She has a history of hypothyroid, right? Good. Vitamin D deficiency, someone said, which I love. I'm a big believer in vitamin D, which is its own thing. And then she's also on she has a bunch of medical disorders. So maybe some of the adverse effects. We all know that DPP-4 inhibitors that treat diabetes 2 can cause bad arthralgias. And sometimes people can get achy and feel bad from various electrolyte abnormalities, depending on what hypertension meds they're on. And statin myopathy is the most common nocebo thing. So common things being common. We just think of this stuff before we get into the crazy rheum disorders. But then someone just mentioned beautifully a great differential of inflammatory arthritis, which include things like gout, which is a crystal arthritis. It's the crystal itself which provokes inflammation of the joint. So it's a kind of inflammatory arthritis. In addition to crystal inflammatory arthritis, there's primary inflammatory arthritis, things like rheumatoid arthritis, psoriatic arthritis. And then good, there's also a kind of inflammatory arthritis. I'm not sure if anyone's aware, it's called erosive hand osteoarthritis. Head nod if anyone's ever heard of that. So classically, when we think of osteoarthritis, it tends to be a non-inflammatory relative to something like RA. But the neat thing about this is that it's eminently diagnosable, and it is passed down from mother to daughter, as it says here in the history. It's something that you can think about using anti-inflammatories for, and even DMARDs like Plaquenil. So good. So you guys did a great job. The differential at this point is mainly non-inflammatory. Then you guys listed a great differential for inflammatory arthritis possibilities. I wanted to hammer home what is inflammatory arthritis. We just went through the major categories of it, but I also just want to, like, who cares if she has an inflammatory arthritis? I'm going to pick on Dr. Olivo for this one. So who cares if she has an inflammatory arthritis? Why is that important for her?
I guess it's gonna change the management depending on if it is non-inflammatory or inflammatory.
Yeah, who has ever on inpatient seen gout? Let me see head nods if you've ever seen gout. Okay, who has ever treated gout with steroids? Head nod or no? Okay, it is an experience everyone needs to have, because when you do it, the patient looks at you like you're the second coming or something. It's like their whole life gets dramatically better overnight. It's a very intense experience. There's almost nothing like it in medicine outside of treating a pneumonia with antibiotics. I mean, it's curative. People were disabled with horrible crippling pains and now they're better. And it's the same logic with all inflammatory arthritis. Inflammatory arthritis, when you treat them with this amazing arsenal of medications called immunomodulators, their whole life gets better. It's very cool. So if you can help your patient identify that they have a component of inflammation, their whole life gets better, like actually. So what are the key elements in the history we need to uncover to figure out if this human has inflammation? Dr. Pietro also started us on the right path. So she was saying which joints are involved. And so with inflammation, if we're not hip to it yet, classically inflammatory arthritis tend to involve small symmetric polyarthritis. So they tend to be small symmetric polyarthritis. So MCPs, which are knuckles, metacarpophalangeals, PIPs, and those tend to be the rheumatoid distribution. So MCP, PIP. They could also involve the knees, the ankles, the small joints of the feet called metatarsal phalanges, so MTP. So good. So we're trying to identify which joints are involved. Big joints tend to be more OA, the low back, the hip, things like that. Good. So we want to identify what joint. What are the other features about the history that you guys want to know to see if this human has inflammation? And you can either speak or you can put it in the chat. I want to hear what you guys are thinking. How can we learn if she has inflammation so that we can make her life much better?
Warmth and swelling of the joint, morning stiffness.
Okay, cool. So swelling of the joint, we're thinking about synovitis. And so where does the swelling come from? It comes from inflammation in the synovium, right? You have vasodilation in the synovium and then fluid leaks out as part of the process of inflammation. So you might have boggy, swollen joints. Good. And then what was the other one? Morning stiffness. So morning stiffness correlates with systemic levels of IL-6. And there's some research demonstrating that morning stiffness is a better correlate of outcome of DMARDs than like other formalized diagnostic criteria. At the same time, it's not a super specific sign. So almost all elderly patients are going to have some degree of morning stiffness. Also, patients with various housing insecurities are going to have morning stiffness because they might be sleeping on the floor. I mean, it's not silly questions to ask your patients when they say that they're feeling terrible. Or do you have a bed? Do you have a pillow? How long have you had this morning stiffness for? And what do you mean by morning stiffness? This is a particular issue if you are speaking with a Spanish-speaking patient or with a different language, because this is a nuance which can be lost across translators and language. So morning stiffness, if you could elicit it, is helpful, but it's by no means specific. So we have a few things in the chat. Presence of B symptoms is good. Worse, which time of day? So good. So we're talking about morning stiffness, and that helps differentiate between degenerative arthritis, which is classically at the end of the day. Presence of B symptoms is good. Typically, that means they have rip-roaring systemic inflammation, and they often don't have B symptoms. It's just not that specific, but it's good if you can find that. Response to NSAIDs is good. So if someone has pain and their pain gets much better with ibuprofen, then that's helpful. So I wanted to flag a few things. So when we're talking about NSAIDs, you guys might not know, but there's basically an anti-inflammatory dose of NSAIDs relative to an analgesic dose. So when you guys are using ibuprofen, which are 200 milligram tablets, you should be using 600 to 800 milligrams if you want to target inflammation. Using 200 or 400 milligrams is just an analgesic dose, and that's highly nonspecific. But if someone's taking 800 milligrams and they say, "Doc, my pain goes away for a few hours, but Tylenol doesn't touch it," you're right. That's a good sign. Something else to think about along these lines: what if they have asthma? They probably are getting prednisone courses from their pulmonologist, right? So you guys can always think about the other diseases that they have and be like, "Yo, when you get a pred taper, when you feel terrible and can't breathe, do your joints get better?" And then they're like, "Oh yeah, I didn't really think of that." It's like, "Oh, that's cool." So that's just another piece of data that you can kind of file away. Pain that gets better with use. Good. So we have stiffness that gets better with use as we work out that inflammation in the joint. Symmetry, asymmetry of joint involvement, very good. Classically, inflammatory arthritis is symmetric, as we said. Timing of pain, alleviating aggravating factors. Yeah, you guys are right on the money. You know, it's interesting. So I teach med students, and I was having lunch with a third-year med student who's like just starting boards. And she was like, we were going through some of this stuff together, and she was talking about the distinction between osteoarthritis and rheumatoid arthritis. And she was like, my attending on medicine was making such a big deal about this, like as though I could ever mistake them. Like they're so different. And I was like, oh, sweet child. The point I'm trying to make is that like this list is fantastic, and you guys have the nuance down. It just takes like seeing a few hundred patients like this to realize that like reality is so much harder than this. And that's why in a few minutes, we're going to get to labs and imaging, which could help us, because often they kind of overlap, and the clean diagnosis is really hard. But good, this is where we start. This is a good history. Before we go to the physical exam and think about how we're going to further help our patient, Ms. Rodriguez, does anyone have any questions about the history and the historical features that we just discussed? Cool. So, physical exam. Miss Rodriguez, and now updating the story with some extra history. So she's a 72-year-old woman with hypothyroid, diabetes, hypertension, lipidemia, sinusitis, who presents with bilateral symmetric small joint polyarthralgias, MCPs, PIPs superimposed on whole body pains bilaterally above and below her waist. Her pains are improved with NSAIDs, though not fully. Hard to exercise, not really improved with rest or activity, and there's a constant hand, quote, achiness that prevents her from opening bottles or painting her nails. She further reports poor sleep, 4 hours a night, associated with snoring, 30 minutes of morning stiffness, and bilateral knee pains worse with walking. No family history of rheumatologic disease. This is like pretty real, right? Like there's all kinds of features that are one way, all kinds of features that are another way. This is good. I did a good job with this one. Feeling pretty good about it. So what do you guys look for on physical exam? So this is not, so let's be real for a minute. So Ms. Rodriguez comes to your clinic, you guys are double booked and running behind, and no one is roomed on time, and you're waiting for your preceptor. You don't have a lot of time here. So what are you going to do first on physical exam? What part of the body do you dive into first? I see. I saw Yoni Balbol doing this with his hands. So I'm going to go with hands. I think that's good. We can get a lot of information from the hands. And, you know, the adage, which is true, is before we examine, we observe, right? And so there's a lot that you can observe in rheumatology. So first of all, to the extent that rheum is the medicine, the musculoskeletal system, you want to see how they walk. You want to see their gait. What are some things that you could immediately address with gait? 1, do they have a cane? 2, is their cane falling? And if it's falling, could you write them a DME for a quad cane that doesn't fall? 3, is it at the right height? 4, are they using it at the right size, at the right height and side? These are just things that are immediately correctable. And if I see a patient who's using the cane improperly, then I'll stop her in the hallway on the way to my office, and we'll just do like a 5-minute primer on how to use the cane. And I'll change the knob and I'll make it the right height. And you just like make someone's life immediately better. Like, that's cool. So good. So you could like watch how they walk and help them use their DME. You could also watch them when you have them go from the chair to the table, you watch them get up. And sometimes they need to swing back and forth like this, which is a marker of proximal leg weakness. So then you're thinking about, do they need, bathroom handles by their toilet? Do they need shower handles to prevent falling? I mean, these are all very practical things that like you could do to like make a human's life better. Good. So that's observation. And then we dive into the hands. Good. So why do we dive into the hands? Because there's a lot of information in the hands. So what are we looking for in the hands? First, you have the patient, put your hands like this, and remind me what we're looking for: swelling of the joints. So when you're examining the MCPs, which are the knuckles, remember the joint space is immediately distal to the knuckle itself. The joint space is not the knuckle. The joint space is distal to the knuckle. So if you guys feel your knuckle with your thumb, and then in a circle kind of roll around it, and then go immediately distal to it, you're going to feel a divot in the finger. And the divot is the joint space. It's not the knuckle, it's immediately distal to the knuckle. So when you push on that divot, can I have head nods if anyone feels it? Do you know what I'm talking about? Okay, it's a little bit of a subtle distinction, but it could make a difference between a good exam and an exam which makes no sense. So make sure that you can identify the MCP joint, because this is a very commonly involved joint with inflammatory arthritis. You need to push hard. And, in you and me, when we push hard, it's not the end of the world, but in a patient with inflammatory arthritis, they'll jump out of the table, and that's called synovitis. It's inflammation of the joint. So we feel for that with MCPs. Then we do the same thing with the PIP. Now, when you're feeling the PIPs, you need to feel like this from top to bottom. You're feeling for any kind of squishiness and any kind of pain, but then you also need to feel from side to side like this. Sometimes patients can hide inflammation in the joint. And if you just do this, you don't really feel it. But if you do this, they jump. So we want to feel for MCP inflammation, PIP, synovitis or inflammation, and then DIP. Okay. Now, if we have a big bony bump on the finger, that's the eponym for that is a Bouchard node. And if there's a big bumpy bump at the end of the finger, that's called a Heberden's node. And can someone just call out what that generally means?
Osteoarthritis.
Yeah. So that's a marker of osteoarthritis. And the reason why that matters is because if they have OA in their hands, they're very likely to have OA in other places. Okay. So if they have full body pain with clear evidence of OA in their hand, then I'm thinking maybe this is an OA picture. That doesn't mean that they don't have multiple things going on, but that really kind of leans me towards OA, which is a very different management than something like rheumatoid or inflammatory arthritis. While we're looking at the hands, we're also looking at the base of the thumb. This is the first CMC. And when we move it around with our hands, you take both of your hands and physically move the base of their thumb around. Sometimes you can feel crepitus, and often patients will just feel terrible in that joint. And 99% of the time, base of the thumb, first CMC, is osteoarthritis. And so that's another helpful marker to just kind of put together a systemic picture. So good. So we look at the joints of the hand, and then we look at the skin. We look for skin tightening. If you guys have a little light, which no one does, you could look at the capillary dropout of the fingers, but whatever, not now, I guess. So MCP, PIP, we look at skin tightening. You want to push on this bump in the wrist. This is called the ulnar styloid, and you push on it, and it's supposed to be anchored by ligaments. And what happens if you have long-standing inflammation in the wrist? The ligaments get weak and it goes up and down, the ulnar styloid, and that's called the piano key sign. So if it goes up and down like a piano key, the bump in the wrist, that could be suggestive of long-standing inflammation. Likewise, the ligaments in the finger, they're supposed to keep the finger straight like this, but sometimes the fingers bend backwards and patients say, I'm double jointed. Okay, so when the finger bends backwards, that's a signal that there's what we call ligament laxity. And the eponym for that is Jacquard's arthropathy. And Jacquard's arthropathy is when the fingers kind of stretch back a little bit. That too is a non-specific finding, but it could suggest long-standing inflammation complicated by ligament laxity. So it's just another piece of data. And we're just beginning to scratch the surface of the hands, pun intended. So like there's so much information you can get by looking at the hands. So you start there. And then of course, you look at the palmar surface of the hand. And the palmar surface of the hand could have things like trigger finger. You look along this line of the hand and you could feel taut bands, which correspond to the A1 pulley, which are flexors for the fingers. Those go away with a whiff of Voltaren gel or ice, or you can inject. So that's a good place to start, is the hands. What else do you think is important in the room exam? I'm just going to, for the sake of time, so the hands and the wrist, we already spoke about. We're going to be looking for evidence of synovitis. We're looking for non-specific findings like Jacquard's and like a piano key sign. We're looking here for like trigger finger for Dupuytren's contracture, for any kind of tendinitis. When you hyperextend the finger, that could suggest that there's kind of a tendon inflammation here. And when you extend it, it gets a little bit worse. Then you make your way up to the elbow. And when you make your way up to the elbow, what's this guy called inside here? Someone shout it out.
The
Olecranon fossa.
Cool. Yeah. So, okay. So olecranon fossa, and here medially, this is the medial epicondyle. And when this is irritated, when you push on it with your thumb and they jump, this is called medial epicondylitis. And this is lateral epicondylitis. And this is where the extentors go in. And by identifying that, patients come in, they're like, oh, my elbow hurts. Their elbow is fine. They have tendinitis and they need Voltaren gel. And they need a little brace here, which you could prescribe them. And they need education on how to hold things with their hands. I mean, people who are maids or housekeepers or anything, when you can identify the musculoskeletal source of their pain, whether or not it's some, sexy vasculitis or inflammatory arthritis, you can like actually help someone by like knowing what's happening. So I would encourage you guys to be doing this. Look for focal areas of tendinitis that could improve with things like Voltaren gel or occupational therapy or PT. Then you get to the shoulder, you do your whole exam. You can look for rotator cuff tendinitis, etc. Okay, the physical exam in rheum is like, it's challenging to overstate how important the physical exam is, and Zoom is just the worst possible way to be discussing this. But I guess I just wanted to flag for you guys that 1, observation is important. 2, the hands is where most of the action's at. But 3, every part of the body is going to have some kind of possible window into inflammatory arthritis or tendinitis or soft tissue pains concerning for fibromyalgia, right? This patient has diffuse myofascial pains above and below the waist bilaterally. So when you're touching places very mildly, sometimes you could even just touch the skin. And that word, there's a word for that when someone has exquisite pain to just touching the skin. It's called allodynia. And it's just extreme, excruciating pain. That's suggestive of centralized pain. Does anyone know what centralized pain is? This is tough. So, okay, so centralized pain is basically when centralized pain is when classically we think of pain coming in peripherally up to the spine and up to the brain. Centralized pain is basically when the brain and the spine kind of amplify non-pathologic peripheral signals. And so, all pain is localized to the brain, but, this is why phantom limb patients who have no arms feel pains because they still have the brain, just localized to the phantom limb. Centralized pain is classic for just kind of having very light touch pains all over their myofascia. It's associated with inflammatory arthritis as well, and with poor sleep and obesity. So sometimes to treat these patients, getting them ruled out for sleep apnea, which it sounds like she might have, and getting them sleeping much better can just magically take away their pain. Cool. So if you had X-ray vision and you could see inside of your patient, what would you look for to know for certain if your patient had inflammatory arthritis? I'm going to pick on Eric Kawagari.
Can you repeat the question? I didn't get the first part.
If you had X-ray vision and you could see inside your patient, what would you look for to know for certain if your patient had inflammatory arthritis?
Changes in the bone structure, like erosion or like calluses and stuff like that.
You're the man. And we're going to look at that in a minute. I just want to be clear though. So erosions on X-ray. So first of all, we all do have X-ray vision. It's called X-ray. You just have to order X-rays. So you can order X-rays of like the hands and the feet and other parts of the body. If you see erosions, that's pretty classic for inflammatory arthritis. And that opens a great opportunity for us to then treat them with medicines to make their life better. But that's a specific finding. It's not at all sensitive. And we're going to get into some imaging, which is a little bit more sensitive. But to be clear, the diagnosis of inflammatory arthritis does not require any special kind of imaging. It is a clinical diagnosis. And so actually, while there's a bunch of classification criteria for rheumatoid arthritis, the actual gold standard diagnosis of inflammatory arthritis is the opinion of a rheumatologist. So it's and there's nothing magical about being a rheumatologist. It's just medicine. So all of you guys have the power to consider inflammation and then begin treating. All right, before we move on to labs and imaging, and then we close it up, does anyone have any questions about the physical exam or the history thus far? Cool. All righty, so now we are getting into labs and imaging. So we have a 72-year-old woman, hypothyroid and all this stuff. She presents with bilateral symmetric small joint polyarthralgias with MCP, PIP superimposed on whole body pains. On exam, she has mild Jacquard's arthropathy. Remember, that's the eponym for ligament laxity. And she has painful synovitis at MCP 2 through 5. So MCPs are the knuckles, 2 through 5, with associated ankylosis, meaning she has limited range of motion. Okay. At bilateral wrists, as well as positive MTP squeeze. Positive MTP squeeze is when you take their foot and you physically squeeze the toes right here, like it's right at the border of where the toes insert on the foot. Positive MTP squeeze suggests it's a pretty sensitive and crude test, but it suggests that something's cooking in their feet, and it's a non-specific marker, but in the right context, it could suggest a small joint inflammatory arthritis. So she also has myofascial tenderness in her bilateral forearms, her chest, her traps, her bilateral thighs, and crepitus in left and right bilateral knees. Do you guys, quick head nod, have you ever heard the word crepitus? Yeah, it's kind of like that creaky, like crumpling up paper sound, right? And that's more suggestive of an osteoarthritis. She has no rashes. She comes to you with recent labs, ANA 1 to 80 speckled, negative RF, ESR 45. I am going to ask Fatima, before we get into the ANA 1 to 80 speckled, negative RF, and ESR 45, given this history and this constellation of history and physical, what do you think is going on with this human? This is tough.
I would still saying common things are common. I'm still like with osteoarthritis.
Great.
And we're still having ANA positive 180, but not that high level to make me suspicious for inflammatory condition.
Got it.
ESR is not impressive for her age.
Oh, cool. So yes, ESR is age and sex adjusted. So good. So for a woman, it's her age plus 10 divided by 2. And for men, it's just the age divided by 2. So she is entitled, she's 72 plus 10 is 82. So she's entitled to an ESR of around 40. So 45 is not that exciting. Good. And then you were just, this is a perfect segue to talk about the ANA and her negative RF. But before we do, just want to throw out a few quick clarifying points. Sounds like Fatima thinks what's going on now is mostly OA because of the crepitus in the knees. Does anyone else think anything else before we go on at this point?
She could have two processes going on. I mean, she's 72 years old. Maybe she's just presenting a little bit later and has like long-standing joint disease, but I think she could have some multiple things going on at once because she doesn't necessarily fit one bucket completely.
But yeah, so that's another teaching point here, Rebecca. That's a great job, is that multiple things can happen to people. Her negative, she has a negative RF, but it sounds like she has symmetric small joint polyarthralgias. So how could that be if the RF is negative? Well, it turns out the most common kind of rheumatoid arthritis in the elderly is called seronegative rheumatoid arthritis, which is when the labs are negative, but they have inflammatory pains in a symmetric small joint distribution. So maybe she has seronegative RA and OA, right? Great. And one quick small thing when we talk about the ANA. So what percentage of the population has a positive ANA in the world? The answer is 100%. So every single person in the universe has a positive ANA, including everyone on this call. And the reason why we dilute it 80 times is to reach a level of clinical significance. So about 10% of the population has a positive 1 to 80. And up to 40% has a 1 to 40. And as you get higher and tighter, like Fatima was saying, it becomes less and less likely that it's by chance. And it probably, has something to do with an inflammatory disease as you get higher and higher and higher, with a few caveats. One, ANA 1 to 40 can kill people. Sorry, let me take that back. Connective tissue disease associated with ANA 1 to 40 can kill people. So you can have rip-roaring lupus with multi-organ damage with an ANA of 1 to 40. So it's not as though low titer means nothing. Low titer just means that there could be something going on. So don't discount someone's potential inflammation with low titer ANA. At the same time, this is not at all specific. ANA of 1 to 80 is 10% of the population, 1 to 10. It's totally possible that and likely that nothing's going on. The vast majority of ANA consults that we get in rheumatology, there's no inflammatory disease. So 1 to 80 means not a whole lot. It's not that helpful. It's also more common to be positive in women. And it's also more common to be positive in people with hypothyroid. And it's also more common to be positive in people who are a little bit older. And so I'm not that excited about her 1 to 80. What does speckled mean? So this, to be clear of what an ANA is, in 1 minute or less, your patient's blood is taken from her arm and put in a tube, okay? Your patient's blood is then put in a dish with HEP2 cells. HEP2 cells are just kind of the basic cell that they use. I think it's a kind of human laryngeal cancer, but it's a basic human cell, which is actually an upgrade from what they used to use, which was rat cells, which had their own problems. But now we have HEP2 cells. We pour your patient's serum on it. We wash away all the crap that's not antibodies. The idea is that if there's antibodies from your patient's blood that attack the nucleus, then it'll stick to the nuclei of the HEP2 blood. So once we wash away all of the other stuff, we then attach an anti-IgG fluorophore attached to like a green fluorophore, an anti-human IgG attached to a fluorophore, so that when you look at it under the microscope, if there's stuff in the nucleus, it glows. Okay, so here are the nuclei in the left column, and because the circles correspond to nuclei, so they look homogeneously lit. That means that your patient has antibodies against stuff homogeneously distributed in the nucleus. What's in the nucleus? Double-stranded DNA. So maybe your patient has antibodies against double-stranded DNA. That's a specific hallmark of lupus. And that's why classically we think an ANA homogeneous is suggestive of lupus. Head nods, if that makes sense. What else is in the nucleus? The histone, right? The histone, so what else? Chromatin. So all of the lupus antibodies tend to have an ANA homogeneous. And so the speckled, the homogeneous, the nuclear, the centromere, it refers to a subjective impression that one gets when they look at the immunofluorescence. But nowadays, we have a panel called the ENA, the extractable nuclear antigen panel, where we don't need to depend so much on people's kind of gut impressions of how it looks. We can just send the different antibodies, or rather for antibodies against specific different antigens, and see what your patient has. The reason is because antibodies against different antigens have certain correlations with different diseases, but at the end of the day, it's all clinical in rheumatology. These just help us make a diagnosis. So that's a long way of saying ANA of 1 to 80 speckled is not that impressive or important. The speckled is just a subjective inference about what you see when looking at the microscope. 1 to 80 is not negative, but it's also like not that impressive. A negative RF, as we mentioned, so rheumatoid factor. What disease was rheumatoid factor discovered in? So it's called rheumatoid factor. It was actually discovered in cirrhosis. So it's a non-specific anti-FC IgG, which means it's an antibody against the FC portion of immunoglobulins. It's a non-specific marker of immune activation, and it's not specific even for rheumatoid arthritis. Its absence isn't that exciting. Its presence isn't that exciting. What it does is it's another piece of data. So if your patient has symmetric small joint arthritis, then they have a high titer rheumatoid, you feel pretty good about that. But if they have a symmetric small joint arthritis and a negative RF, that in no way excludes rheumatoid arthritis. It's not that specific or sensitive of anything. And then we already discussed the ESR 45. So what other labs would people like to see? And just throw stuff out in the chat. What other labs would you like to order? And then we'll get into the imaging and then we'll wrap up. So labs first, what labs do we want to see? Oh, people have been putting stuff in the chat. Damn it. All right, you all did a great job. Epicondyle, allodynia, classic, very good. Bone erosions. Okay, so we have, now let's do the labs. So we have anti-CCP, good. This is a much more specific marker for rheumatoid arthritis. Anti-CCP is still not totally specific for rheumatoid arthritis. You could see it with any kind of lung disease. So the reason is, well, you don't have time, but good. CCP is good. What else? CRP, LFT, anti-CCP. So CRP is good. C-reactive protein is it's a more reliable indicator of systemic inflammation. The ESR is an age-old way of looking at IL-6. And the reason is because IL-6 stimulates the acute phase reactants in the liver, one of which is fibrinogen. Fibrinogen causes the red cells to stack and fall differently in a tube. But there's all kinds of interference that happens with ESR, and it's a super old, crude test. So what you could do is measure acute phase reactants directly. And one of those is the C-reactive protein, or CRP. So good. Anti-double-stranded DNA antihistone. Okay, I mean, I would send that if she came to me, probably as a one-time thing. It's a different question if I were asking rheumatologists what do you send versus asking primary care doctors. And in clinic, if you saw 1 to 80 speckled in someone like this, I probably wouldn't send double-stranded DNA and I wouldn't send antihistone. And the reason is because it would be so unusual for a 72-year-old woman to have lupus. And in fact, if she did, I would suspect it were something like drug-induced lupus. But sure, you can send it as a one-time thing. Okay, what about what other? Okay, good. So we sent the lupus markers, we sent the RA markers, no problemo. Sinusitis. Can anyone think of any inflammatory diseases which have to do with sinusitis? Yeah, so the ANCA vasculitides, right? Would you guys send ANCA serology? Would you not send ANCA serology? Are we all good stewards of cost-conscious care? Do you want to send it once just to make sure? So I'll
I think,
yeah, I'm sorry, Eric, what were you saying?
no, I was saying sending those markers would depend how long the patient has had sinusitis. Was it associated with any other symptoms, like URI kind of symptoms? If it did, then, I'm not going to send those markers. But if the patient had those symptoms, like for a long time, like chronic, just sending them.
Yeah, cool. That's great, and you're totally right. So I'll let you guys know that I definitely fudged with the case a little bit, but the ethos of this case came from a real woman in my clinic who has embodied this. She really did have this kind of chronic sinusitis. And ANCA vasculitis is really unusual. I was like, fine, she has joint pain and sinusitis. I'll just be sure. And her PR3 came back really high. And I was like, damn it. and it's probably a fake positive. So then I sent it again, and then I got a CT scan of her chest, and she had like ground glass opacity everywhere. And I was like, damn it, like, how is that possible? So the bottom line is that like, if you don't send it, you're going to miss them, right? And so even in primary care, it's my opinion that if someone comes in with serious concerns and has the protoplasm for autoimmunity with hypothyroid, or even if they don't, if they just have any exam evidence suggestive of anything cooking, I'd err on the side of caution and at least send something once, or if you're not sure, you can always send them to me. But she ended up having real ankylosing and is now much better on Rituxan. And then Fatima, by the way, mentions UA, and she's 100% right. And I would also get a spot protein to creatinine ratio in the urine. So cool. So there's a lot more to discuss about the labs and the imaging. We could just run through this quickly together before we put the case together. So the imaging, I basically just threw a few images together just to show you guys kind of what's possible in the realm of rheumatologic imaging. So, you know, here are some x-rays of the hands. These joints are normal. We have the MCPs here, the PIPs and the DIPs. This is a knee. What's this thing called in the middle of the knee? The chat's blowing up. Meniscus. Okay. So yeah, so what this is it's a radiographic sign that's called chondrocalcinosis. And chondrocalcinosis, I'm trying to go back. Chondrocalcinosis suggests CPPD, crystalline arthritis, and that is licensed for us to try prednisone to make their whole life better. CPPD could also hide in the MCPs. And so what you might think is rheumatoid can sometimes be called pseudo-rheumatoid pseudo-gout, which you find by tapping their knee and finding CPPD crystals. Really neat. This is a little bit different than the former picture. You see that there's all these bumps. Ah, crap. Here, there's all these bumps at the joint space. These are called erosions that you guys beautifully pointed out before. And this is pretty pathognomonic for inflammatory arthritis of the hands. And this is rheumatoid. This is what advanced rheumatoid looks like. You also see carpal crowding down here. Like these bones kind of look like they're crowded on top of each other. Ultrasound of the hand. So erosions are super specific, but you're not going to catch them a lot. You guys can actually, in Epic for your patients, if you don't know if they have inflammation or not, you could order specific ultrasounds of the hands. And an MSK radiologist will do it. It's zero radiation. It's really cheap. And you can know a lot of information. So here's the metatarsal head and the phalanx, and you see this black area over here. This is an effusion. And when there's an effusion at a joint, it's synovitis. And then here we have a positive Doppler sign, which suggests active inflammation. You guys could all order this for your patients. And once you find that out, then you can put them on a little bit of prednisone, send them to me, and their whole life is better. MRI of the hand. If you don't know what's going on, get an MRI of the area, and you can find really subtle erosions that aren't on X-ray and sometimes even missed on ultrasound. So putting it all together, this is an elderly woman with multiple issues who presents with a symmetric small joint polyarthralgia, MCP PIP superimposed on whole body pains bilaterally. On exam, she has mild Jacquard's with painful synovitis at MCP 2 through 5 with associated ankylosis of her wrists and a positive MTP squeeze. She also has myofascial tenderness in her bilateral forearms, chest straps, bilateral thighs. She has no rashes. Her recent labs are as such, and her newer labs demonstrate a negative RF and negative CCP. She has a weekly positive CRP, a vitamin D, which is quite low, normal CK and aldolase, so she doesn't have a myositis. So her presentation is therefore consistent with seronegative rheumatoid arthritis with secondary fibromyalgia superimposed on osteoarthritis, right? So seronegative RA, like we discussed, it's just the most inflammatory arthritis that there is, particularly in the elderly, and it's a clinical diagnosis. If you guys think about squeezing the MCPs, PIPs, the MTPs, the ankles, the wrists, and find a symmetric small medium joint arthritis, this is a total plausible possibility. You could start them on a little bit of pred, see if they get better, and if you want, you know, there's all kinds of options. You could discuss with us. Secondary fibromyalgia. Secondary fibro happens secondary to rheumatoid, lupus, Sjogren's. It's in about 40 to 50% of our patients in rheumatology. So just because someone's diffusely achy and they're complaining and it hurts everywhere, that doesn't mean that they're just a complainer and they have nothing going on. They could also have an underlying inflammatory arthritis. The neat thing about secondary fibro is that when you identify the driving factor and treat it, their fibro goes away. It's really cool. Osteoarthritis is just everyone has osteoarthritis. So take home points, and then we'll open it up to some questions, concerns, and musings in the last minute or two. Patients often have multiple diseases at once. Consideration of inflammation could change the game for your patient. Be on the lookout. And then rheumatologic diagnosis is clinical and it's supported by labs and imaging, though seronegative and non-radiographic diagnoses are common. And that is it. That is my little primer for you guys. I open it up for questions, concerns, or existential musings.
First, guys, unmute yourselves. Oh, I see Yoni. There you go.
Yeah, I was gonna say, so in this case, you said you would start treating her with steroids. You wouldn't start like a disease modifying and then see how she responds to that, and then say, okay, she has rheumatoid arthritis, she possibly has osteoarthritis, we give her some NSAIDs too. Like, what's your treatment plan for this case?
So my treatment, that's a great question. So I'm being cavalier when I'm saying just start everyone on steroids. Of course, there are some serious downsides to glucocorticoids, particularly in a patient with diabetes and hypertension like this lady has. Also in an elderly woman, just generally speaking, it's just not the best thing. So one totally reasonable option would be to give her what's called a prednisone trial. And a prednisone trial is pred 10 milligrams for like 2 weeks or so. So 10 milligrams is not high. All of our bodies naturally make 7.5 milligrams a day. So pred 10 is just a little bit of a bump. And when patients have inflammatory arthritis, they feel like new people. So when you call them in 2 weeks and you're like, how do you feel? They're like, I haven't felt this good since I was 20. And it's like, okay, you're a good person for methotrexate. Right? Another first line DMARD in someone who is elderly, who has diabetes, is Plaquenil, because Plaquenil, in addition to being, or hydroxychloroquine, in addition to being a fantastic immunomodulator, also lowers sugars. It lowers A1C 0.5 to 1. It lowers lipids. It's an antiplatelet. It's kind of like a metformin, statin, and aspirin all in one, and it has cardiovascular protective effects in all patients with inflammatory disease, and it's about the safest thing in the universe. So I would probably, this woman, I would probably give her pred 10 for 2 weeks and then just start her on Plaquenil. And then if Plaquenil wasn't enough as monotherapy, I would escalate her to methotrexate. But that's a great point about prednisone, and I probably would just give it to her as a little bridge to take the edge off her pain, and then I'd start her on something else.
Thanks.
So how will you monitor like this patient? So besides like the clinical improvement, like would you send any labs like CRP, ESR, or?
That's a great point, Dr. Olivo. So, so there is a concept in rheumatoid, which is getting, basically it comes from the diabetes world, which is treat to target. So the target in diabetes, 6.5, you either have it or you don't. And then that target changes depending on whether you're, it's you guys know, right? So the target in rheumatoid now is low disease activity, and there's various different scales that you could use to treat to target. One is called CDI, one's called RAPID-3. They're all clinical scales. So you can just look at the extent of joint pain that they're having one day. And so if you have 20 hot swollen joints, and then I put you on Plaquenil and you come back and you have 10 hot swollen joints, then we're heading in the right direction. So that's a great point. If they have elevated inflammatory markers, I can go into it as well. But it's always kind of a reevaluation of whatever objective and subjective metrics you have to see if the benefits continue to outweigh the risks. And then, yeah, it's a good question.
What is your approach on NSAID use in patients with higher risk of bleeding, like history of GI bleeds, organ aspirin, history of ulcers?
Yeah, so I was trying to find who said that. I'm just scrolling through my little pictures here. It's not happening, but great question. So, so NSAIDs are, I think that they get a bad rep I think NSAIDs are much safer than we give them credit for. If anyone's interested in the safety profile of NSAIDs, you could check out the Precision trial, New England Journal of Medicine 2016, where they randomized 24,000 patients to receive 3 different NSAIDs, Celebrex, naproxen, and ibuprofen. You could check out the rates of different adverse effects that happened over like a year or so. Certainly NSAIDs increase the risk of GI bleeding. And if someone has an active peptic ulcer disease, no bueno. If they had a really brisk GI bleed in the past, probably not, particularly if they're on aspirin or dual antiplatelet. So your point's well taken, but I do think that we tend to kind of blow out of proportion this risk. So what I do is NSAIDs also really help people's lives, and it's a first line med for osteoarthritis. So in the absence of like really hardcore peptic ulcer disease or a history of severe GI bleed, I have a risk benefit conversation with the patient. I'll let them know it could irritate their stomach. I prescribe them PPI 40 milligrams prophylaxis to be taken before breakfast daily. I have them take their NSAIDs with breakfast. And what I do is I recommend that if you're going to be using any kind of NSAID chronically, then you start with it for 2 weeks at a high dose. So for instance, with naproxen, I will give 500 milligrams twice a day for 2 weeks. And that's like really high. I give it with the PPI. And if they can tolerate it and if it really helps them, then I don't keep them at that for that long. It's all risk benefit. I have young people at that dose for a long time, but in the elderly and in people with at least a moderate risk of GI bleed, I lower it to a moderate dose. And then that trial, the Precision trial, actually tested people on moderate doses of NSAIDs over a long time. So if you guys want to get a sense of real life data about the risk of bleeding, check that out. But it's relatively low. NSAIDs are awesome. And I would encourage that we use them more, being mindful of the fact that there are just some patients who should not get them. And as long as we're mindful about that and have risk benefit conversations and put them on PPI prophylaxis with a period of few weeks to see how they do before committing them for a long time, I think that they're really underutilized medications.
So much, Dr. Kaplan. I'm sure there are many other questions, and hopefully if it's okay with after our attention, I have to say, I had no idea I could learn so much from a virtual physical exam. Thank you so much for your time.
Yeah, thank you guys. It's a pleasure. And my email is first name dot last name at Mount Sinai. So any questions, concerns, or further existential musings, I'm always around. Thanks, guys.
Very kind of you. Thank you so much. Have a nice rest of your day.